Welcome back, everybody. That was a great keynote this morning. Thank you, Dr. Stead. We're going to switch into our second edition of our Partner Spotlight. Part of the joy of working at Georgia Tech is you get to engage with new partnerships and develop and build them. And we're always engaging with bright minds out there and bright companies, one of whom is going to be our next Partner Spotlight, which will be ShareCare, with whom we hope to have an extended, sustained relationship. So I'd like to invite Jen Martin Hall from ShareCare, the Vice President of Communications.
Good morning, everybody. Again, my name is Jen Martin Hall, Vice President of Communications at ShareCare. You may or may not be familiar with ShareCare, but we are a health and wellness engagement platform that was founded about 4 years ago by Dr. Oz and Jeff Arnold, the gentleman who founded WebMD. So Jeff and his team decided to get back into the healthcare game to really try to make good on what they always envisioned WebMD to be. And what we've built together, we're very proud of, and we're also really excited about the possibilities for the future, particularly as we're looking and exploring different ways to partner with Georgia Tech, is a patient engagement platform that can go forward to consumers, but then also we're building patient engagement platforms and population health management tools for large institutions. The largest customer of ShareCare actually is the Department of Defense, and every active duty soldier in the military actually uses the Army Fit platform that ShareCare built. And then we also just recently signed a major strategic partnership with CHE Trinity Health, where we're going to be helping them with all of their population health management solutions in the communities that they serve. Not just touching the patients that come into the clinical environment, but trying to reach the people in the communities through these free online tools to enable them to get better care. The last keynote that we heard, it's so inspiring to me now that the terms patient engagement, population health management, people-centered health system, actually people's eyes don't glaze over as much anymore as they used to about 18 months ago. And we think that that is a massive opportunity, and all of us at ShareCare, for one, are really looking forward to being able to bring that back and normalize it for the consumer. And that's one of the things that I think that we are most excited about in exploring a deeper partnership with Georgia Tech, is reminding ourselves that the consumer needs to be at the center of every single thing that we do. And that's why we got into this to begin with. And the consumer is never the stumbling block, right? There are regulations, whether it's FDA regulations or different legal regulations, or simply systems that we're facing within hospitals, or electronic systems that aren't going to talk to each other. We can't get electronic medical records from one place to another. But again, we'll do everything we can to focus on simplifying things for the consumer, and are just really proud to be a part of the Atlanta community and also a friend of Georgia Tech's.
Thanks, Jen. Next up, on the other side of the spectrum, what happens when a partnership matures and it becomes very solid is we get to have folks like Sherry Ferrugia be part of Georgia Tech as well as part of Children's Healthcare, and I would like to invite her to come and talk about the relationship with CHOA.
Good morning, everyone. Thanks for coming out to the forum. This is an annual event that we certainly look forward to, and I'm thrilled to participate in it this year. In December of 2011, Children's Healthcare of Atlanta committed $10 million to a research fund for Georgia Tech. Georgia Tech matched that with another $10 million. And people often ask me, as the managing director of this partnership, why Georgia Tech? Why would Children's Healthcare of Atlanta invest in an engineering school? And it is because what do engineers do? Oh, thank God. I'm so glad that the engineers actually answered that correctly. So yes, engineers solve problems, and that is exactly what we are doing for Children's Healthcare of Atlanta. And we are working with them in a wide variety of research projects, from big data, analyzing Medicaid claims, looking at PHR data, all the way over to how we can integrate that in with genomics data and have a longitudinal view of the patient. But also, one of our early successes was standing up the first Center for Pediatric Nanomedicine in the country. And we are engaging clinicians at Children's. We are engaging clinical researchers at Emory with our engineers, and we are solving and working on problems like how might we cure sickle cell, gene editing, how could we work with nanotechnology to develop a process to literally cut out the defective single gene. So everything from data to something that is very long-term and complex like single gene editing. My role is more on the operations, strategy, and finance side. I am a joint employee, and I am literally paid. I am leased to Children's Healthcare of Atlanta 50% of the time, and no, it did not come with a car, unfortunately. But I have an office at Children's Healthcare of Atlanta. I work very closely with my counterpart, Leanne West, who is the Chief Engineer of Pediatric Technology. We share an office here. We share an office at Children's, and Leanne's role is more to connect the clinicians with the engineers. On a daily basis, we are always asking the clinicians, what are your problems? How can we solve those? And sometimes that results in, basic research on the academic side, and other times it may be more applied, something that we can solve the problem in 12 to 18 months. So we are thrilled to be part of the relationship. Children's Healthcare of Atlanta, a lot of folks do not know this, but they are the largest in terms of volume children's healthcare facility in the country. We see 2/3 of the pediatric patients in the state of Georgia, and something that we're very proud of is this year, I guess it was a couple of weeks ago, we reached the milestone of our 300 heart transplant. So we're thrilled about that. Beth Howell is in the audience as well. I want to say hi to her. Worked with her for years at Children's, and now she is the CEO of the Atlanta Ronald McDonald House Charities, and we're thrilled to have her here as well. And she's still very involved in Children's and is a wonderful mentor. So if you have any questions, I'm here most of the day. If not, my contact information, all of them not up there, someone here knows how to find me. I can assure you.
Thank you, Sherry.
So I'm really loving this new feature of the forum, the Partner Spotlight, because it allows us to, shine a light on all the different types of partnerships that we engage in at Georgia Tech. And today was a fun one because we got the whole spectrum from an emergent partnership to a multi-year, multi-million-dollar relationship, to the extent that we have joint employees now that manage and support that engagement. And it really shines the light on the fact that it is the crosstalk and the partnership and the collaboration and the engagement from the academic side all the way through industry, from long-term, well-established companies to a terrific ecosystem of emergent startups. That is our world, and that's where we're trying to make a difference in healthcare. So, terrific lead into our panel, because our panel represents that spectrum, represents that passion, represents and just picks up beautifully where Bill Stead left us this morning on how do we turn the focus from the patient to the person, how do we focus in the home, how do we focus on the community, how do we transform healthcare by moving all of these different levers, because we know so many things are fundamentally wrong with the system we have now for the problems that we have today. So I get to introduce the panel moderator, and then Daria is going to take it from here and introduce and start off our panel. So let me tell you about Daria Long-Gillespie. She is Dr. Gillespie. She is an MD, MBA, and is a board-certified physician at Emory University Hospital. She's also the Executive Vice President of Clinical Strategy at ShareCare, and you just heard a little bit about ShareCare. And continues a great deal of work as a national spokesperson for the American College of Emergency Physicians, and including her work as an assistant professor at Emory University School of Medicine. Daria earned her medical degree from the University of Rochester School of Medicine. She did her residency of emergency medicine at Yale, and then completed her MBA from the Harvard Business School. So with the absence of having Georgia Tech on that resume, it's a pretty good resume. We'll work on that Georgia Tech degree. After residency, she joined the faculty at the Harvard Medical School. She worked in the ER at Beth Israel Deaconess Medical Center in Boston, and I think only recently have we managed to lure her to the Atlanta area. If you don't know her from her terrific background that I've just told you about, you may have seen her because she appears regularly in print media as well as radio, and has been on CNBC, Fox News, Dr. Oz, as well as she's the host of her own Shared Care Radio for iHeartRadio. So you've probably heard from her or engaged with her at some point in time during her career and her time here. She is, of course, also a published author with text in emergency medicine and other topics such as plastic surgery, orthoscopic surgery, as well as then having to understand the financial side of hospital strategic and finance business development. So truly a person that has wrestled with the complexities of the healthcare system as a whole, and I'm thrilled to be able to hand this panel off to her. So welcome, Daria.
Thank you so much, Beth. I'm going to have the rest of the panelists come on up. All right, come join me, please. I have my phone here to pay attention to time. I promise I'm not texting. Let's see. I can reach. Thank you so much. All right. Thank you so much for that wonderful introduction, Beth. I'm just going to rotate a little bit if that's okay, so I can see the rest of the people on the panel. And I'm thrilled to be here and alongside this incredibly impressive crew of people alongside me. So as both a physician and executive, we've been seeing how in the past few years, new technologies, increasing consumer engagement, and a move to share and make more transparent data is really transforming healthcare. It's changing how we provide care, when and where we can monitor our patients and care for them, and what we do with that information that we're getting. So that's one of the two things we're going to be discussing today are what are the new data points that we can get on our patients and the consumer, and what are some in the future? And then how do we use that data to prevent adverse events, increase consumer engagement, and ultimately improve outcomes? So with that, I'm going to let each of the panelists give a quick introduction of themselves. Go ahead, Ellen.
I'm Ellen Bulge. I'm president and CEO of THA Group. A little about myself. I'm a very old woman. I've been in healthcare a long time. I was first in hospitals and thought that nothing was sexier than being a hospital administrator. And then I saw the light and I got into home care. I formed THA Group out of a vision that it was possible to have health care for life at home. And THA Group has a group of companies that range the continuum of everything you can do at home. I believe that people should be able to age in place and that they should be able to die in their homes, surrounded by everything they love and everyone they love. If you've read Atul Gawande's book, Being Mortal, he will tell you that in America, that is not a model that is very easy to pull off. I keep thinking, though, with the advances in technology and with our evolving enlightenment, that I'm going to do it. But anyway, I keep trying. Now, what Gandhi said was, to really influence the future, you have to pay great attention to what you do in the present. And I think Americans also ascribe to the theory that health is wealth. And I've added knowledge is power. So in 2000, 15 years ago, I decided I would give the people in my market power, and I gave them remote personal telemonitoring. And I tried to tell them, now you can manage your health at home. And it's been a wild ride. They have done some miraculous things with the information and the tools they've had. What we've done is evolved all of that into Right Health, which is our newest company. And I'm rather proud to say it does a lot of the things that Dr. Stad presented and continues to work on the evolution of making all of that remote, virtual, and less labor-intensive. So I believe that power to the people, that you do engage people by giving them everything they need and coaching them, giving them the tools, centering everything around them, and then miracles can happen.
Thank you, Ellen.
I'm Robert Choi. I'm the Chief Strategy Officer and founding executive of Culane Healthcare. And Culane Healthcare is kind of a play on words. It's about collaboration and innovation. We're a subsidiary and joint venture company formed under LG Corporation. We're formed in about 2010, right after the Affordable Care Act passed. LG had an appetite to get into the U.S. healthcare market, and we're leading the strategy, commercialization, innovation across the LG family of companies to deliver innovative healthcare technologies. And our focus is actually, Ellen is going to be my favorite client hopefully one day, because we are totally focused on long-term post-acute care, community-based care, and digital health apps for a connected care framework. And we have a specific population health platform called Interactive Virtual Care Team. For real quick background, I have been in the long-term post-acute care operating space as Vice President of Operations for Hardin Healthcare. We had about 34,000 patients across the country, nursing home, AL, home care hospice, pharmacy, rehab. I had sold a physician business entity. Prior to that, a lot of other provider organizations, sold to .com to IBM in 2002. And so I've been in a lot of startups, both in technology, also in bricks and mortar healthcare. Glad to be on the panel. I'm actually from Austin, Texas, and for a long time after I went to Emory, I thought I wasn't allowed in the state of Georgia for a few years, but haven't gotten caught. I'm okay. What we're trying to do here in Georgia is also interesting. It parlays into what we're doing across the country and also across the globe. The silver tsunami is a big issue. It's not just here, but also in other countries. And we have some opportunities to use supportive and assisted living technologies for not just healthcare here, where it fits our payer schema and the healthcare ecosystem and the politics in the area, but being able to converge that in other markets as well. So that's our space. One of the other areas that we focus on, what I'm really interested in is the synthesis of software and hardware, specifically around data and interoperability. So I think we'll talk about that more.
Thank you. Lucy?
I'm Lucy Ide. I'm CEO and co-founder of Remedy. We're a health IT company focused on improving the quality of life for people with chronic conditions. And currently, we are currently focused on diabetes management specifically. We have a product in the market that helps sort of the whole spectrum of diabetes management, from the patient and better understanding of how to self-manage their condition and the cause and effect of my choices and behaviors and taking my medication and being active or not, and how that impacts diabetes. And there's really a fundamental lack of understanding of that in the market. And a lot of what the previous session this morning spoke about, of how do we help consumers better visualize and understand their data, how do we share the proper data with the care coordination team, the proper data with the care givers who are making decisions about, do I change a medication, do I recommend a change in lifestyle for this individual. So really trying to get from self-management through care coordination, population management, all the way to individual patient management. We're an Atlanta-based, Georgia Tech-based startup. A little bit about me. So I'm a physician by training, did the MD PhD program here at Emory, and worked in venture capital and communications technologies before that. So I try to bring all that together to merge sort of what's buildable with what's usable by clinicians, with what's fundable by the venture capital community. And those are sort of the barriers really to creating a product that can make a difference in the marketplace. Happy to be here.
Great. Well, thanks. Thanks for having me here, and thanks for joining us. I'm Omar Inan. I'm an assistant professor here in electrical engineering at Georgia Tech, and I'm fairly new also. I've been here for about, I guess, a little over a year now, which has gone by very quickly. Before that, I did my schooling in electrical engineering at Stanford. And as an undergrad there, I was also a competitor on the track and field team. I did the 10K and 5K. No, that's not true. I don't know why you didn't laugh when I said that. You don't have to be polite. I actually did discus and shot put on the team. After finishing at Stanford, I was in the pro audio industry, actually, of all things, for about 4 years as the head engineer of a company that built kind of products that competed with this microphone I'm wearing right now. It hurts me to hear the feedback that we just heard a second ago because our mics would not have had that problem. And now in my lab here at Georgia Tech, we work on non-invasive physiological monitoring technologies. So on-body sensing and also sensors built into normal things we interact with in the home and outside the clinic to be able to provide proactive strategies to manage chronic diseases and other sorts of rehabilitation kind of applications outside the clinic. So excited to be here and join these wonderful people on the panel.
So I'm Jim Ray. I'm a professor of computer science here at Georgia Tech in the School of Interactive Computing. And my training is in computer vision and machine learning, and my particular interest is in essentially technologies for taking streams of data that might be produced by a wearable sensor, for example, and extracting information about that from that data, particularly relating to people's health-related behaviors. So we're very interested in the behavioral side of health and trying to put that side on a firm sort of quantitative footing through the use of a variety of different kinds of sensing. And so we have sort of two center-level activities that I'm involved in, directing the Center for Behavioral Imaging, and we're looking at, in that case, children's behavior, particularly in the context of developmental conditions like autism, and trying to understand how to sort of quantify and assess behavior in a scalable way that could apply to eventually all the world's children. That's a research effort funded by the National Science Foundation. And then more recently, we just got a large NIH Center of Excellence grant partnered with the University of Memphis to look at sort of health-related behaviors in adults. Primarily, we're looking at smoking cessation and heart failure and the behavioral consequences of those conditions. And that's a new effort, again, building out this analytic infrastructure from on-body sensing to interventions and health-related information. It's great to be here.
Thank you very much. You can see we have a very incredibly esteemed and impressive panel. So to start off with, the first question is, there are a lot of new gadgets out there, and the point of ultimately is finding something that improves outcomes. So what are some things that you're seeing that you think that actually will truly improve outcome in patient health? Alan, if you could start us off.
We've actually done several demonstration projects with hospital systems, with physician groups, trying to show very early, we started some of these in like 2005, to show that taking a patient and putting them in partnership with a physician and with a provider that worked with the patient in the center. And I will confess that I don't even like to use the term patient. I like to say that they're people, and I'm honored to get to work with them. But I know that physicians usually want you to say patient if you're dealing with their patient. But the patient and the physician and then the telehealth provider would have a three-way partnership, and we even signed a contract that we would work in a different way. We would develop a system of how we would work together. And I won't get into all of that, except that when we have done this with physician groups, we had some pretty astounding results with their frequent flyers. And when they were compared against the Medicare data at large for 30-day rehospitalization rates, which for the data at large, the landmark Medicare study was about 24%. Ours was like 7%. And then at 6 months, the data at large is 50%, and ours was about 20%. We also, with a big hospital system, applied our Right Health type model to their 33% admission rate at 30 days. And everyone knows that value-based purchasing is here for hospitals. In fact, you might be interested to know that the majority of Georgia hospitals will be receiving penalties. In New Jersey, there is only one hospital that will not get a penalty. That's how bad it is for hospitals. They're having a lot of pain. But this hospital had a 33% running for years, and the first year we worked with them got it to 12%, and the next year 5% for congestive heart failure. So I think we can show that we have outcomes that are demonstrable with telehealth. And there are lots of other things, but I won't go on and on.
Those are fascinating, wonderful successes. Right, Bobby, how can you speak to that as well?
So I'd agree with the same things that Ellen talked about in terms of the evidence and remote patient monitoring technologies, medication management technologies, video visit technologies. I think that the opportunity to incorporate more of the ambient sensing world, specifically in senior housing, it's really easy to see those ambient sensors, the motion sensors, the Internet of Things, smart appliances, being able to see, did the resident open the refrigerator door in her kitchenette today, those kinds of technologies, combined with all the other things that we use for aggregating behaviors and vital signs. I think that that's a really easy step. That's something we can do now. I think the challenge becomes down the road as we see more wearables and sensors. Specifically, I'm talking about the long-term post-acute and the elderly population. It's that where do we aggregate that data together? Otherwise, we're accessing 15 different portals and 16 different data analytics tools. And because that data hasn't been standardized, and even if I look at the EHR world, there are so many flavors of standards. And I think that becomes our biggest challenge. I think there are opportunities now. The technology works, the basic frameworks work. I think as we get to more invisible technologies, things that are a little bit more frictionless, like the ambient sensing technologies, the behaviors that we detect from smart appliances, as we get into that world, since it's so reliant on data, we still need some work to do on standardizing what is a care navigation platform, what's a population health platform look like, how do we get data from everybody. And because the politics and the competition that exists in the sensor space still, and because that space moves so quickly, is it even worth doing an interface right now to this company or that company when it's not going to be here tomorrow? And so I know if you go to these tech conferences and venture pitches and South by Southwest, it's a different group of people every year. It's 80% of them don't exist next year. So also when we look at the evolving world of sensors and wearables and M-health technologies that you'll see on phones, the world's moving so quickly. I think LG Electronics, our sister company, they showed their LG roadmap for phones. And where in 2017 we'll have the first rollable phones, the first bendable phones, the first flexible phones, and that's within 3 years. So when you think about that velocity, I think the biggest challenge becomes, I think we need to get the data framework first. We know that technologies, sensors, and things will help. We know interactive virtual care frameworks like two-way video visits and secure messaging, that will help, but we need to get the data first.
The framework for what to do with it.
Right.
And as Dr. Stead mentioned, putting it within context.
Exactly.
Refrigerator opening plus the blood sugar.
Right,
plus
right.
Those together. Which brings us to Lucy and Rimity, the blood sugar.
Blood sugar. And it's a great point. I mean, diabetes is the poster child of expensive, poorly managed chronic conditions, which is why a lot of people, including ourselves, are focused on that space. It's sort of the low-hanging fruit of let's see what we can do in diabetes with technology, with mHealth. And there have been multiple people that have shown the impact of that. The impact of better aggregating diabetes data, the glucose data, just for the individual, getting it in a way that they can visualize it. I mean, traditionally from home glucose monitoring, the process of docking that meter to a PC through a USB cable, was so cumbersome that consumers just wouldn't do it. And so there have been some technologies like Gluco, that's a cable that hooks your meter to your phone and can get the data on the phone. And, you can see an impact with something that simple of getting glucose data into a format that people know what it means, much less sharing that data with their healthcare team. So, the good thing about diabetes is it's fairly easy to show some level of impact. There's, an app out there from WellDoc, which made a big, splash. It's one of the first FDA-approved mobile health apps. And they've been able to show an impact in hemoglobin A1C outcomes with patients using their device. I think the challenge is how do we scale these technologies in a cost-effective way? In our own development, we've been able to show the impact on A1C control of having clinicians use clinical decision support tools to make more data-driven decisions about patient management. But then it really is more of a platform question and a scalability question, and how do you integrate that into the existing health system, and all the interoperability questions and the workflow questions are what becomes sort of the next barrier.
Julie, how do you get the data, and then what do you do with it as well?
Yeah.
All right. Well, moving into the earlier stage of some really amazing scientific research that's happening here, Omar, if you could speak to that and some of the things you're doing that show potential outcomes improvements.
Sure. So I guess I'll start with, I think that on the science and research side of it, one of the driving forces for me and one of the things that keeps me really interested and excited about this and why I'm kind of on that side versus on kind of commercialization at this point is that I feel like the two areas of the sensing side in particular that are being ignored to some extent and really need more attention are really physics and physiology. So I think we need a better understanding for many of the sensors that we use. Even something as simple as the optical sensing that we use for SpO2 measurement in the clinic, which is used everywhere. Right? Many of us have probably had one of those finger clips. But just the basic understanding of how the volumetric expansion of the arteries locally leads to that signal optically actually is still kind of a major research question for many people. And of course, there are many great papers out there on it. There are review papers. There are people making these devices all the time. And many of the smartwatch technologies that are measuring heart rate use that particular mode of actually interrogating the body with reflectance measurements of this optical signal. But by not really understanding what's at the heart of that signal, I think we're missing out on a lot of information that's just inherently already there, and we don't necessarily know what to do with it. That waveform shape that you measure, what does it mean? How does it change with temperature changes? There are some sort of more anecdotal, kind of qualitative understandings of that, but I really think getting to the heart of the physics and the physiology behind that can uncover a lot of new research areas and also make for big impact, breakthrough kind of products down 10 or 15 years down the road.
Omar, I know you'd mentioned before that much of the lifestyle trackers that people have now are very lifestyle, but not a quality of data that can be used by researchers and physicians for outcomes, and that's somewhat of an obstacle?
Yeah, I think that that's definitely an obstacle. I think that, so for many of the fitness trackers, for example, we track something called steps taken, which really is just, it's done because of, from the computing and programming side of things, it's actually easy to pick out that variable. It happens to be something that the accelerometer sensor just spits out to you, and so you can measure it. But of course, if I sit here with a wearable and I'm doing all these hand gestures while I'm talking because I can't keep my hands to my side to sit still, the activity tracker is going to think I'm burning many calories, whereas probably not so much. Right? I think that improving the quality of what we measure from these sensors, and there are many people actually who've demonstrated better activity recognition algorithms just using the accelerometer that's already in the phone, where you wouldn't necessarily need a wearable device. And so I think that by improving the quality of what we can measure from devices and improving our understanding of what those measurements mean, that's going to be kind of the new wave of improvements out of the sensing side of things, at least.
Yeah, so let me follow up on what you said and add one more point. So, one way to think about this whole kind of ecosystem is really from sort of data to knowledge. So you're talking about the just explosion of devices that make it even easier than ever to collect data. And then the question comes, what do you do with all that data? Mm-hmm. How do you make it actionable? How do you extract information from it? And there I think we really need to enlist the help of the data science research community, the data mining communities. But those communities need to be grounded in biomedical research and understanding, as you're saying, of physiology and physics. We need this partnership. We need to work together with experts that really span the spectrum of health. And that's a challenge both in terms of coordinating research communities and providing platforms. So a platform that can enable a researcher at an institution that has excellent ideas about data mining or pattern analysis, but doesn't have a clinical collaborator and can't access their own health data. How can we set up systems that facilitate and include those individuals so we all can contribute to this problem? And then I want to plug one more thing, which is really the behavioral dimension of health that I think is lagging in terms of our ability to really get high-quality data. And that's a place where I think sensing is going to play a big role, but we're still in the early stages of understanding how to get accurate behavioral data from these devices. And there's this huge sort of literature in behavioral medicine, largely based on laboratory studies about how people react in different situations and how those reactions have health consequences. We really know very little about what happens in the field, in actual day-to-day life. When someone is trying to stay abstinent from smoking, what are the cues that are possible triggers for that person? What is the reaction they have to those cues? We really don't know the kind of hard data there at all. And that's another space where mobile sensing technologies can really help us get more insight. So those are areas that I think are really exciting to push on.
So it's really getting the information from in vitro, the research we get in the lab, to in vivo, what they're doing in their own homes. Which brings us to our next point. So we can have great technology, but if the consumer is not using it, then it's sitting on the shelf and nobody's engaging with it. Bobby, I know you had mentioned, the average lifespan of an app being fairly short. How can we create things that are habit-forming and sticky and engage them?
I think there are a couple different strategies depending on the audience. If I look at relatively well-adult audience, that's people that typically download apps from stores, app length expectancy, life expectancy, very, very short. But if we tie that back into some convenience features, so when I think about, for example, an automated home, and that automated home app, if there are healthcare features or components tied together, you're always accessing that app. It's not just that one tool that you launch once in a while. It has to be as frictionless as possible. It has to be as invisible as possible. I think that's where the consumer electronics retail players have some advantage because they concentrate so much on user experience to make that as pleasant as possible. But then also when you look at whether it's a well population or a very, very elderly population, very, very frail population that is using an app, it has to be frictionless and it's invisible in terms of process with the healthcare providers. So that two-way bidirectional interaction, that interactivity between a provider and a patient is really valuable to make sure that there's a feedback mechanism. It's not just you taking a vital sign, maybe you'll get a call, maybe you'll get a smiley face on your app. It's more about this is an integrated part of the care process. So when we think about care teams and care coordination, care navigation, and all these other buzzwords we use in terms of the care management process, you can use these technologies, but it has to be well folded into the operations and care delivery process. And the challenge there, of course, is that every healthcare ecosystem is different. Everybody's doing it differently. There's not a standardized process in care navigation. Kind of goes into what I think is maybe a good effort by CMS, this new Transforming Clinical Practices initiative, this new grant program that was announced last week, and something that we're working on. It's to make it more scalable use of sharing data and being able to have mobile care teams and having patient participate in that. I think that's valuable. I think there's also some opportunity to involve informal caregivers. Potentially 40 million informal caregivers in the country we do not take advantage of in terms of family members by 2030. So we need to incorporate that as well. So the more, when you think about stickiness, I think it's more about surrounding the patient, not just telling them it's up to you, but there's other involvement there.
Surrounding them, being the feedback loop.
Right.
Yeah.
Yeah, I was going to jump in. Obviously, I work with the elderly, and someone turns 65 every 10 seconds. And by 2030, 1 in 5 Americans will be over 65. And in home care, 87% of the population, the Medicare population, have 3+ chronic diseases versus regular Medicare population and the general population, 27% have 3+. So the population that I'm speaking to is a very ill, brittle, frail population. So that colors my remarks. But what we found, we did a study on emergency room recidivism. And this hospital challenged us, well, no, don't show us what you can do with heart failure. Show us what you can do keeping people out of the emergency room. And I swear I think they went and got us the worst of the worst. But it was very interesting. You wanted to say, well, golly, this is kind of simple. This lady is homeless. Did you know that? She became homeless and is living under the bridge. And, oh, did you know that this lady lost the last family member and she's so lonely, going to the emergency room is her social activity for the day. So sometimes I think, and I'm among people that I have really no right to be, they're all so brilliant, but I am in this real world, and sometimes it's the simple things that we haven't even thought of that we miss. So one of the things that we've done, and obviously downloading, because we've got to produce the highest outcome at the cheapest cost. That's the definition of value, right? So we use lay health coaches that have these relationships with these people, because I'm still a believer, and I'm sure we're going to figure this out through video, and we're playing around right now with bidirectional video. I think it'll be better than right now this telephonic health coaching. Definitely, I agree with you, Bobby. But we use this to gain the patient's trust and to get this relationship going. I do think social media will connect these people when there aren't family members, and that's something we should all think about. How are we going to develop systems for that? But sometimes it's the health coach that absolutely keeps the person out of the hospital. And I like to say I'm not just in the post-acute space. I should be in the pre-acute space. I should keep people from ever going to the hospital, not just deal with them once they're out.
So in some patients for whom a tech consumer app may not be a solution, empowering a healthcare coach to touch them, but that coach is empowered by a tech solution. You have a layer of personal in between.
That's a good point.
That is what we see in the ER. People come for many reasons. And so, Lucy, you had spoken a little bit about patient segmentation as well, as far as getting it to be more habit-forming and understanding the customer.
Yeah. I mean, I think, so we, on the tech end, are in the business of data aggregation, predictive analytics, decision support, all of this fancy, cool stuff, but fundamentally we're dependent on the data being generated in the first place. And it's a huge problem in diabetes, getting people to actually test their blood glucose. There's the vision in the future of Google or whoever, cracks the code and has the contact lens that measures your blood glucose non-invasively. May or may not happen in the short term. But if you think about that fundamental stickiness problem of why don't people test their glucose as they're told to by their doctor, I'd argue because there's nothing in it for them often. I don't have diabetes. I often test my glucose as we're testing devices and trying to get data into our system, and it hurts. Like, my finger hurts, for a while, then I'm having to pick which finger to prick the next time. And so I think we're fundamentally have to back way up on this stickiness question and say, what problem are we solving for the patient? What problem are we solving for the care coordinator? What problem are we solving for the treating clinician? And I often talk with our customers and with my team about one of the basic principles you learn in medical school, which is don't do a test if it's not going to change your behavior somehow. So why test blood glucose if you're never going to use that data to drive a clinical decision or to drive a behavior? And today, and for decades, that's what's been happening in diabetes. Physicians can prescribe to patients to test their glucose twice a day because that's what's reimbursed. Because that was what was negotiated between the device companies and the payers. So if we think about that and say, well, gosh, what if we shifted our mindset to let's test glucose for a specific reason, to enhance that consumer's understanding of their diabetes, of what happens to their glucose pre and post a meal. And so maybe then they understand a little bit better how their meal choice impacts their diabetes. Or what happens to their blood glucose before and after taking a medication. So now they start to understand how that medication impacts. Then you can start to affect medication adherence, because if they see that positive effect. So we try to back way up there in the stickiness question, and then in the application, in the user experience to address that. Everything consumer-facing is around positive reinforcement of, am I meeting my goals, or the behavior choices, back to this sort of what's the real-life context. Is that context, having a positive impact on my diabetes or not? And so I think if we can help the consumer see that they have the opportunity to sort of be part of their management and affect the change, all the way through to the clinical care of why on earth do we take half a day off of work to go in, drive in traffic, sit in a waiting room for 45 minutes, talk to a doctor for 6 minutes about data, about data on a device, and then leave and do it again in 3 months. I mean, it makes no sense. And so if we can help consumers that we're trying to solve that problem for them too. Your time is valuable. What if your clinicians could see that data, every week instead of once every 3 months that you had to take half a day off of work? So I think those are the things that drive stickiness, is that we're actually bringing value to the consumer, and they'll want to keep engaging for that reason.
That's educating them and then empowering them to know what they can do about their blood sugar and interaction with
it's
their
giving them a
physician.
sense of control over their outcome.
And Omar, how do you design products that are going to be more useful and more used by the patient?
Well, that's a great question. I think that needs to be handled in any of the device designs, and it's not, unfortunately. There's a really good point brought up by both Jim and Lucy, that the value of what you're getting for the patient who's using the device or for the doctor has to exceed the obtrusiveness of the patient of using the device. If it doesn't, then they're not going to use it, and they shouldn't use it. So on one end, you have this axis that, if there was a figure, I'd put it up here probably that I normally do, but there's an axis of kind of going from invasiveness to unobtrusiveness in terms of how painful or how much time does it take or how much does this really take away from the person to do the test. And usually there's an inverse correlation between that and how much information or knowledge are you actually going to get out of that test or out of that sensor. And so in my lab, and I think in other people also at Georgia Tech, there's actually many people doing this and around the country as well, that in the research domain, there's people attempting to build devices that are both unobtrusive and provide a greater amount of knowledge or information. I think the main technological enabler for doing that is multimodal monitoring of the physiology and the behavioral context. I think that's a really good point. So rather than just monitoring heart rate, I can monitor my heart rate, maybe something about my hemodynamics, and how did that change as I just walked up a flight of stairs. And so in the clinic, this is standard. They do exercise stress testing. If they want to know about brainwave activity, there could be functional imaging or evoked potentials. There are many active protocols where they try to understand the physiology in the context of something the person is doing or some stressor. And it allows you to get a lot more information for the same level of obtrusiveness. So I think that's one of the key kind of ways forward on that one.
Fascinating. Jim?
Yeah, so just to follow up again. So I think, so also, in addition to what everyone has said, I think there is this tendency that the devices or the methodologies can be these kind of point solutions. So one physiological measure, and let's build the least obtrusive device that gets that at a high quality. And I think part of the challenge also is thinking about the ecosystem. So for particular health conditions, maybe the ones with the biggest economic cost or the largest urgency, what are the variables that we really need to measure, and then push that back down into the stack of how you design devices and build them out, so you really are building toward this ecosystem and not just developing sort of single solutions. And I think that's, again, a challenge for the community to really come together. There's all these different groups working in very diverse areas, and there tends to not be, a kind of overarching connectedness between them. We're starting to see that. There are these academic conferences emerging that are kind of looking at these broad areas of health, and they bring researchers together. There are industry meetings that play a similar role. But that community building part, I think, is really key, and it's really still just kind of starting to happen in some sense. So.
And if I can jump in, I think this is where the funding agencies are actually moving in some ways in a direction that can really benefit this. I mean, Jim's, of course, NIH Center of Excellence is a great example of where he brings together physicians, data science researchers, sensor designers, and there's kind of this interdisciplinary mix. We also now have kind of a new NIH grant in our case. It's not a Center of Excellence, not at that level yet. But in our case, we have 5 kind of institutions around the country. We're working on hypertension and finding a better way to do cuffless blood pressure measurements for people who actually may or may not know they have hypertension. This was a NIH effort that they kind of put together this request for proposals specifically for India in this case, actually, for low resource settings. There are maybe 1 in 3 people there who have hypertension who don't know about it. And unfortunately, the risk of mortality is just incredibly higher for hypertension if you don't know that you have it, and so you're not treating it. So I think that these types of, if the funding agencies are listening and can continue to make these sorts of efforts where they bring together the engineers with clinicians and scientists as well, physiologists, then I think that we'll see some major progress on these sorts of big disease problems.
So it's bringing everybody, the various parties together to identify what we should be measuring, and then use design intelligence to create something that is unobtrusive for the patient as much as possible, and that educates them so that they see the outcomes. Speaking to integration, one of the things we see is all these different data sets, and there's your Fitbits and your blood sugar and your weight scale, and they're all going in multiple directions, and nothing is integrated. We've spoken a little bit about context. How do we get to that point where they are integrated so that it's something in parallel with the patient's own day and the physician's workflow, which is something that we're going to need to be able to empower the patient as well as understand their outcomes. Lucy, can I start with you for that?
Sure. So I think we have fundamentally had to address this because the blood glucose monitoring market is a mess. It's a saturated market in the U.S. Every diabetic who needs a glucometer can get one through their insurance or Medicare or from their doctor. And they have all been proprietary systems that only sync with their own technologies. And so sort of starting a company in that context set us up well to have to deal with this more broadly as we have integrated activity data and nutrition data and geolocation data. And all of those data sets are actually much easier because many of them are made by consumer electronics and technology companies who don't think in the regulated medical device way. And so, pulling in and being able to provide that context to the glucose data, mostly through OAuth integrations for us and API integrations has been incredibly easy compared to how do we deal with getting the medical data, whether it's laboratory data, EHR data, or medical device data into our system. And so, one of the ways I think is for things like, Bobby's working on what's the platform that all of this data can reside on so that applications like ours can then consume the data from a platform that has already done that data aggregation piece as far as the medical device and health system data would be a huge help. And everyone in my shoes has been waiting to see who is that going to be. And, there'll be more than one person in that marketplace, but the electronic health record companies really have not sort of stepped up to that. It's just not their business. And so it would be incredibly helpful if, a small company like ours cannot fix the interoperability problem, but we would be really excited to see who's going to step in and sort of help us get that data stream from a single source, because it's never going to become, the device companies just don't have the incentive to fix that themselves.
Right. And it almost does have to be a third party, because if one of the EHR companies did it, then Epic and Cerner would have to cooperate to share data together as well. So maybe the third party will be able to liaise between the two of them. I know, Bobby, Ellen?
Well, Daria, I mentioned that there have been a few players in this space, and we've been aligned with one that actually comes in and it's designed for physician practices, and it lays on top of the EHR of the physician practice, and it basically pulls out from the physician practice EHR each evening into a dashboard so that it's real time and it's configured to pull out if the physician practice is participating in an ACO or has a medical home, all of the elements for the quality metrics that are necessary, and then basically it can sort based on individual physicians, group of patients, and whether the evidence-based practices are being followed by that individual physician. But then also for the group at large, it can sort by the type of patient, so all the diabetics. It's really kind of what you're talking about, this outside party coming in, because it's trying to be the tip of the iceberg and leave all that other EHR data below the surface.
An interface in the dashboard, which is sort of what you're working on as well, correct, Bonnie?
Yeah, I mean, our strategy was actually backing up. LG is a world leader in healthcare, acute care technology, hospital information systems outside the U.S. And a long time ago, there was a plan to bring that platform to the U.S., but like you said, Dr. Gillespie, it's hard to battle with the advocates and cerners if they know you're going to be a competitor. And so if our other core business is population health management, that would not be a really good move to compete against these guys. So we look at this, there's the Sarah Bareilles song, King of Anything. And I think about that because I don't know what the EHR companies are doing, thinking they're the king of anything, but you look at even the largest ambulatory EHRs, the biggest acute care EHRs, there's a SMART score. It's a validation tool by the government. And when you pass the CDA of some of these leading EHRs through this SMART score, it sometimes don't even pass 50%. And some of these are leading EHRs in this country. So how is it that we can do this without somebody volunteering, raising their hand? And it's a time and money issue. So one of the first things we did to enable this population health initiative is we went and recruited HIEs. We recruited HIE executives and team members, R&D guys that have built HIE successful ones, and they're the ones that have put together interoperability in the past because it's time, money, and people. And then a lot of the politics of convincing EHRs to integrate to you, and also the vendors that are in the wearable space and sensing space. But the key is that common customer. That common customer is the most important holy grail. If you have a common customer, a big hospital system that says, I have Epic, I have Athena, and I have Nike Fitbits out there, and I need this to integrate, go work with LG. And that's what drives these conversations. And then we're spending tons of money. But that is a challenge for, I think, the vendors in this space are specifically in one area because it's not worthwhile. It's not worth the money because it costs hundreds and hundreds of millions of dollars, which for a hospital or for a big company, it's a rounding error maybe, but it isn't for early stage commercialization.
That's really the case. It's saying if we go along with Stanford and Stanford comes with us to go talk to Epic, then we have a chance of making this work. It's true.
So if I may follow on that, so I think another issue to sort of think about is this whole issue of kind of privacy and security where this data is concerned. Mm-hmm. So there are, for existing hospital information systems, obviously solutions incorporate those features, but as we look out at the broader ecosystem of data, this is a huge concern. And most people that collect data don't understand how de-identifiable, which means your ability to manipulate the data and infer private information about that person. People don't really understand how that whole process and how that works and what the risks are. And then, how do you develop kind of standards that incorporate as part of the most basic layer privacy and security mechanisms? So you're not building each component of this process, you're building a separate solution to those issues, but those are instead integrated into the fabric of what you're doing. That's a huge challenge. We really need to engage those parts of the high-tech community that have expertise there and get them to start thinking about these data types and the risks that they entail.
Yeah, just going back to that, one of the pillars of our conversations with vendors or with health systems always comes back to our philosophy that we want the data with the patient. So we have a patient-mediated information approach, kind of our commercial, private, blue button type approach, where we're giving the patient the information. If they're going, if for example, there's a city or state where the HIE has completely failed, we'll want the patient to download it back to their phone, which goes back to the cloud, but it's under their control, right? As long as we have some sort of agreement with that health system or vendor. Because otherwise, we're going to fall more behind. And this is such a problem in the U.S. It's not a problem anywhere else, not to the extent it is here, because you are on more paperless systems outside the U.S., or you have one-payer systems. There aren't these barriers. And a lot of these barriers have to do with the health ecosystem makeup in a particular community, what payers they have, the competition between the hospital and their payers and other hospital and their payers. I think that if we can put as much data in the hands of the patient, and if we believe that patient-mediated is the route to go, I think we can solve a lot of the other issues because it becomes a right. Now, how that gets legislated, I don't know if that'll ever happen. But theoretically, it should work.
So by doing that, Bobby, you're making the patient kind of the steward of their information?
Yeah, I think that defeats a lot of the barriers. You already have a right to get your health records, whether you have to pay for them or not, and you have the right to share that information back to another provider. It's kind of like that old patient passport, that medication list that patients carry around on paper, and you have another provider redline or add something, and you go to another provider and you show that. It's that same, almost most efficient process, unfortunately. We can do that through apps. We already do that in other industries and other verticals, so apply that in this space. The problem, again, is if you go to a hospital that does not have pipes or the agreement built with that aggregator of information, you're just self-inputting information. Self-input information, I think, was the failure of those early health vaults and other things. And I think we need that information to be driven by the provider so it's as clean as possible. But in lack of that, I think there's a big role for care coordination, care navigation companies to take that piece of paper and reconcile that, kind of like that medication reconciliation process, to manually update that record.
At ShareCare, we kind of talk about having your healthcare all in one place. Mm-hmm. You need the pipelines, the patient-generated health data, right, and then you also need the lab work and the right, data from the EHR. So getting back to something we've been talking about as well along is I want to kind of move into a quick closing lightning round for everybody. So I'd like to know, everybody get about 30 seconds, 45 seconds to answer this. 5 years from now, what are we going to be talking about? For some of the product guys, research guys, where's the data going to be coming from? Is it going to be coming from my wrist, my pocket, and my smartphone, or some pill I swallowed that's measuring who knows what? And then maybe, or where is that being stored? Is it being stored in my phone that I'm carrying around, or a cloud in the PHR, or is it something that we're not even talking about? Ellen?
I'm doing a CMS bundling project with Medtronic, and I recently saw their new, not even out, injectable, tiny device, smaller than a AAA battery, that goes in 20 seconds, lasts for 3 years, and will predict 15 days in advance an exacerbation of heart failure. So I'm going to guess that we might wear things in our bodies.
Inside.
Chips, devices, things. They've got an implantable device that will stop the tremors and a lot of the symptoms of Parkinson's coming out. Really cool stuff.
Fascinating. Bobby?
Okay. I hope we'll have some beginning conversations of commercialization stage robotics for supportive and assisted living technologies, because what we're talking about here, a lot of these things, they're tailored for the U.S. healthcare market and the U.S. healthcare delivery system and reimbursement around that and the workflow. But robotics is something that's universal that we can deploy around the world. That silver tsunami that's affecting us, there's some countries that don't have long-term post-acute care supports or industry, so they're relying on daughters and sons to stay at home with their parents. And that's not going to happen because the family natures and dynamics aren't there anymore, or not the same ratios. So if you don't have home care in place, if you don't have kids to take care of you, how are you going to deal with these super aging populations? And I think robotics has to be a solution. It's not just sensing. It's being able to intervene or support or help. And I think there's a lot of great R&D going on in the world right now across the globe. But hopefully we're getting to a commercialization conversation or something that's becoming real.
So I think the phone will have become the center of sort of this healthcare hub, and that mHealth and telemedicine and all of this will just be normal to all of us as part of how healthcare is delivered, and hopefully more of sort of the automation of closed-loop systems and data, that we generate, that goes to the care team and comes back seamlessly to the consumer, will be in place. I think my biggest concern about that is sort of the digital divide and how we're going to address that. If that's really going to become central to our healthcare system, who is that leaving behind? And we're going to have to deal with that as a country.
Absolutely. Omar?
I think we're going to have to deal with the big thing we'll be talking about is FDA in a few years, and how are we going to actually ensure the quality of all these billions to trillions of sensors or wearable technology gadgets that are going to be everywhere. And I think we're going to realize that many of them actually are fairly inaccurate as it is now, and we're going to have to actually focus on making them better and then proving their accuracy in rigorous kind of scientific Sounds boring, but experiments and studies.
We'll need you to create those. Jim?
Yeah, so for me, it comes back to behavior. I think we have this kind of tagline we use at Georgia Tech. We call it behavioral imaging. So we make the analogy to the way medical imaging really just transformed medicine last century. And I believe this is the century of behavior, and we're going to have technologies that let us measure, analyze, predict based on large amounts of behavioral data. That's my sort of 5-year plan.
Okay, wonderful. And now I think we've gotten to the point of Q&A. So, Allison, do you want them to come up to the microphones?
Yes.
Okay, perfect. So come on up.
But I'm shy.
Well, then go. Can everyone hear him?
There's a webcast.
Oh.
You have raised the issue of security and privacy, and I guess it's a theme. It's a recurring theme throughout the discussion that we've had yesterday and today. So this is not going away. So what do you tell your customers to assure them that you're secure and their data is private? Or are you aware of any standard that can help you make that statement? Thank you.
Yeah, so let me start and then others can follow. So I'm not aware of any standard. I think you're raising a super challenging problem for which I don't think the academic community really has a great solution at this point. And I think what I would really advocate for is that whatever the solution is, it has to involve some mechanism of educating the folks that are using the technology. And that's often the part that's omitted. So we have some incredibly secure, socket layer protocol for internet transactions, but people are told, well, just buy this thing online and it's going to be okay. The technology is going to preserve your security. And I think it's a real challenge. How do you sort of really let people understand what the risks are so they can make an informed choice about what to use? I don't have a great solution to that, but I think it at least should get more attention. I don't think you see as much talking about that as you do about the technology solutions.
Yeah, I would agree. I went to get new eyeglasses the other day. I went to my doctor's optometrist's website, and there's a form. And I couldn't tell if it was going to be a secure transaction. It didn't have HTTPS on it, but it had a relatively good-sounding technology at the bottom. And I looked it up, and I couldn't tell. It looked like a startup. I'm not sure what it was. But it sounded very healthcare IT related, and it looked very flashy. The website looked nice. I think that consumer trust is a big issue. And I think that goes with not just the platforms that the consumer electronics recognizable names are doing, but with anybody, even with the consumer electronics guys. And I know that we do testing on our products, and sometimes we have to go back and revise because there's security concerns. That's a big issue. And there are third-party tools that have to validate what you're doing and third-party opinions, and that costs money. And so there is that danger, I think, specifically right now on this noise of so many apps, so many sensors, so many technologies. I hearken this back to these day trading seminars at airports a long time ago where anybody would go and pay to learn how to do day trading. And now the same thing goes on with healthcare startups. You go and learn how to do a healthcare startup. A lot of these guys don't have any business being in the healthcare space. They don't care about the patient. They don't care about regulatory. They don't care about compliance. And so those are the most important things in our space. The problem is going back to standards and what the EHR, the dominant guys have done. The dominant guys have really murkied the water on what's going to be happening in the future. You have to play up to these guys. You have to play up to a health system that's using XYZ. I'm not going to mention the EHR that scored 49%, but it's heavily used. So when you have all these things coming out, the only solution is the interoperability stack. If you're an HIE company, or you're an HIE technology company that builds these interfaces, that stack has to constantly update. Unfortunately, probably 80% of the HIE interoperability stacks and interoperability in this country, those stacks were built many years ago and based on many years ago technologies that they've been bolting on. It's like renovating a house. And so there's an inherent weakness to that as well. So we haven't solved HIE issues either, but I think that component, that interoperability stack, can solve some of the issues on cleaning, master patient index, consent, things like that. If there's a patient that doesn't want their substance abuse information to be disclosed or exchanged, there's even a problem with that because many EHRs don't know how to filter that out. Some HIEs don't know how to filter that out. So we're still really, really kind of in an infant stage in this. Unfortunately, we've spent billions of dollars in this country on interoperability. It doesn't work. But I don't know. This is more me ranting than saying that there's a solution here.
I think it will come with it will require partnership because you do a dichotomy. You have the HIPAA at the hospital where I can't even tell another physician about a patient without 18 signatures. And then you have these people who are doing consumer apps and features, and it's being posted on Facebook, whatever your blood pressure was for that day. So it really will require a close partnership to make sure that we are staying in tune with the trust of the patient and the consumer while not hindering innovation.
Well, Daria.
Really quick on that, for someone who's, building a company and trying to comply with all of this and sign business associate agreements and go through a HIPAA audit, and we actually have a lawyer full-time who works for us who worries about all of this. And then you implement all these recommendations, and nobody can figure out how to set a password that complies with the uppercase, lowercase, symbol, number, greater than 9 characters, So then there's the real life, can people still use it once you make it compliant with all of the best practices?
Right. You can't impede the innovation with it.
Just to add one thing, I serve on the Home Care Technology Association of America's advisory board, and we had the Office of the National Coordinator and the FDA and the Federal Trade Commission basically all in one place, and they said that they have reached a definition of which apps would have to be FDA approved, and it would be anything that a physician might rely upon for a diagnosis, right? So a blood pressure a physician might rely on, or an eye test, and so things that right now are on the market and you can just get, they're going to be pulled.
Yeah, it would be a big obstacle. Go ahead. Yes.
First off, real quickly, I like LG, but I have a Samsung. It's got the little finger sensor and all that little heartbeat sensor and all. So the technology is getting micro-miniaturized into where the cell phone is going to be bigger. Secondly, going to the fact about you were talking about in vivo testing, I offer my wife. She's available for any kind of testing you want to do. So,
much appreciated.
You're welcome. You're welcome. As long as it's at no cost. The other thing is near-field, RFID and near-field communication. If you build homes for people who need either independent or need some assistive living requirements, you can build in the RFID into the house. You can put sensors like on the refrigerator handles, on the doors, on the shower door handles, so that when the person is going in, you're getting that information, and then you have that available to send. If they have family members, they get that. If they have a doctor, they get that on their dashboard. So that, I don't know if that's some of the technology or where we're leaning toward, and that to make the house more interactive with the individual.
Can I take this one?
Go for it.
Please do.
So LG, as you know, it's a consumer electronics company, appliances, things like that. One thing on our solutions group, we don't care what platform you have for these apps. We're not like Samsung or Apple. We are all platforms. But
and that's a good point. That's the way it should be.
It should be that way, right? And now I'm going to have Apple hitmen on me. But I think that for smart homes, that's a big initiative we have. Not just smart senior living communities like nursing homes and assisted livings, where those technologies are really in the dark ages. Big opportunity to upgrade senior living communities, but also private homes. So you have these Del Webb, Sun City type communities or naturally occurring retirement communities. When they develop new buildings, which is the easiest way to get in this, to automate and make the home smart, RFID, near-field communication, ultra-wideband, there's a lot of potential in this space. I think that maybe the scientists in the room, that there's research going around LiDi, light technologies for networking. There's a lot of opportunity in this space, but again, it becomes, there's an information layer somewhere. So we have to put the information layer down. Then we'll have that established to pull in this other information from sensors around the room, around the house, motion sensors, other things, lots of different technologies for health sensing if you get that all together. But when you get to some foreign countries, you go to Asia, you often don't see people with metal keys. It's because they have some sort of chip, right, a smart chip, whether it's in their phone, in a fob, or something like that. When our engineers came over to the U.S. and they saw seniors with green tennis balls and these walkers, and also big keys and these pendants from 1970s for life. Lord, they just couldn't understand. There's so much potential we could do with RTLS, with wearable sensing for vital signs, and then combining that with smart door locks, with just saying that you are within the kitchen, whether you put motion sensors or not, but using near-field communication. There's a lot of potential there. It's not that expensive. So, again, it becomes the modernization of what does a senior house look like? And then it becomes a money issue, because the government's not paying for this.
And then alluding to a point that you were saying about the difficulty in the United States, the one main issue with the United States is we give people choice. Other countries, you have a medical plan. Here it is. It's all either standardized or something. Americans like to have choice, and by such, you've created this healthcare I won't say monstrosity, but this healthcare, behemoth, essentially.
Yeah.
That feeds off of that. So thank you.
So, general question to the panelist area, if that's okay.
By all means.
So there's, the problems that keep you up at night, the barriers and the things you worry about. But there's also, the passion or the vision that keeps you going. So what does success look like for you at your gut in terms of, what healthcare is going to look like going forward when you and all the like-minded folks in the same space who are working alongside you? And I don't think my mom's on the webcast, so I'm going to use her as an example. Don't explain that to me as a professor, but how do I describe to my mom what healthcare is going to be like when all of you are collectively successful?
Jim, I'll let you start with that one.
Okay. Well, again, I'm going to sound like a broken record, but to me, it comes back to behavior. So I think individuals, through the things they do every day, the choices they make, the decisions they make about how to organize their lives, they're having a huge impact on their health, on their long-term outcomes. But most folks just don't understand those relationships. They don't really know, because you get sort of recommendations about the average American, right? But no one's the average American. So you really want information that's relevant to you as an individual that can help you understand, sort of difficult trade-offs you might need to make, in organizing your life. So I think for me, the passion is that one day we'll be able to do that. We'll be able to give people, actionable information. This is what you've been doing. And then not for an average person, but for you, what is the consequence of this stuff that you're doing? And then think about, if that's what you're really anticipating or wanting to have happen over your lifespan. And then giving people the tools then to make those, if they need to make changes in their behavior, giving them the tools to do it, not just saying, be tough and, abstain and so on, but really helping them, identify the things that are the triggers, the cues that are kind of working against their best intentions, and then giving them kind of mechanisms for handling those situations, diffusing them in various ways. I think this is the real power in some way of technology, is that it puts that kind of control and that even responsibility to some extent back, in the hands of the people whose health we're talking about. So for me, that's a really huge challenge. It cuts across technology and policy and so many other spaces. I'm struggling to learn, all the things I feel like I need to learn there, but it's really exciting.
Sure. Okay, so I guess I'll give a simple example with my own family, actually. So my grandfather is hypertensive, and he lives in Turkey, actually. So that's where my family's from originally. I was born here. And what he has to do is he has this blood pressure cuff, which I guess he purchased their automated kind of thing, which the WHO, for example, it says is notoriously inaccurate. Okay. And he measures his blood pressure every day and has to take some medication for that. And then he has to also, if the blood pressure is above a certain other threshold, then kind of realize that and take another medication as well. Now, he's kind of approaching 90 years old. This is really fairly difficult for him to kind of manage that and make that decision. I think that, first of all, we need to have technological solutions for someone in his position to be able to measure his blood pressure without such a clunky and difficult device to use that's wrong. I think that's absurd itself. The second part is then somehow, this system of opening up the pills and kind of taking it out, manipulating it, trying to get one pill, hoping that you actually got one, remembering whether or not he took it or not. You have this person who's, we have neurodegeneration, and so at some point it's harder and harder to remember whether or not you've actually taken it. I think we need to see these sorts of things, like you were saying, become more closed loop. become more accurate, become easier for people to use. And what specifically I think will get us there, I don't know. I think it's going to be a multitude of technological innovation, behavioral, social kind of innovation, and also the clinical community kind of working together with all those partners to make it happen. But I think the current state is so sad that it has to be much better than that.
It will be, we hope. Lucy?
So I'll stick with diabetes as the example, I guess, of, how can we get to a point where when someone is, if we talk about type 2 diabetes, diagnosed one day with type 2 diabetes, and that's not like this thing that happened to them and sort of a surprise. I mean, nobody wants that. Nobody says in 10 years from now, I'd like to develop obesity and type 2 diabetes, and then I'd like to learn everything about my pancreas and insulin and glucose. And I mean, it's this horribly overwhelming experience. And as we talk with a lot of consumers, everybody remembers that appointment. And then, I went home to the kitchen table and spread out all the pamphlets they gave me and the glucometer and the lancets and this and that. And maybe I cried, or I tried to explain to my spouse, I have to do all these things, and do I have to stop eating everything? And so I think if you back way up to education, we've gone out and talked to kids of known families that have diabetes in their household, and they have no idea what it is. They don't even know that their family member has it, or they don't know if it's a blood sugar thing, a blood pressure thing. So somehow, from an education point of view, we need to start a lot younger with people understanding healthy, active living and health consequences. But then how do we make the technology sort of a seamless piece that supports that patient education, that supports the understanding of their health condition and how they can manage it, and again, sort of giving control and power to the consumer of, here are your behaviors and the outcomes, and you can impact this. This is within your control. It's not something happening to you, and your healthcare team is here to work with you. They're not here to manage you and then sort of send you home all by yourself, and then judge you and manage you again the next time. And I'll just say one more thing, that we need to take that all the way through to the nurses and doctors and help them be a lot more satisfied with their job. I mean, it's a very frustrating space right now for practicing clinicians. And so how do we sort of get them back to doing what they're passionate about helping people and working with people and educating patients in a 6-minute appointment? How do we get rid of that problem?
Thank you.
From LG's perspective, from LG CNS's perspective, our goal is to transform expectations in healthcare experience. So when we think about the healthcare experience and how difficult it is, whatever population you're in, whether you're a provider, patient, or family member, we have this notion that we want to make the provider experience as smooth as possible, make technology match their workflow as well as possible, be configurable for different healthcare ecosystems and settings, and then for the patient to make things as frictionless as possible, as pleasurable as possible in using their different technologies, their patient-facing technologies. And eventually, hopefully, as we get to more better speech recognition technologies, I guess some of you guys have seen the Echo product come out, more sensing through that instead of actual tactile touching. And then how do we make the family member more engaged? So when we think about modern healthcare teams, they're usually mobile for house calls and home health and population health management. How do we enable them? How do we keep them in the loop? And how do we enable family members to be in the loop? So again, it comes back to this buzzword we keep going back to at LG. It's an interactive virtual care team that's high tech and high touch. And how do we make that as smooth as possible throughout the continuum?
Ellen?
Well, my mother's 95, and she won't leave her home. So Del Webb, building new smart homes, won't get it. I think we have to have the sensor kind of devices and the behavioral monitoring kinds of devices that go into elderly people's homes because they've been in them for a long, long time. My experience is they don't want to leave. I think that in the future, technology will allow us to do more and more virtually, but we have to connect the people, the elderly, with other elderly people who are trying to self-manage the same types of conditions. And I think we will use more and more lay people, family members in the education, the coaching, the reinforcement. I totally believe that we will be making it easier for family members to have conferences virtually with the mother, with the doctor, with themselves in New York City. I think that we have to have an integrated platform and be agnostic to what the technology is, but it's all virtual. And it has to be very much human behavior driven, because without that, we've got to activate that person.
Yeah. I think it's really going to come down to innovation and collaboration from literally people in each part of this panel. Kind of represents every step. It's designing the product that measures what we need in a way that's unobtrusive. It's educating the patients and working with them to understand why they should be using it, then connecting them with their physician and their care team and their family members to both predict adverse events and help them achieve their healthiest life, which at ShareCare we like to call living in the green. So hopefully we can reach that in 5 years or 10. Thank you very much. Do we have any more questions? I'm not going to hold up lunch. So thank you so much for your time.